Hello and welcome to this UKFPO presentation introducing the new Foundation Programme curriculum. I'm Tony Choules, the Chair of the Academy of Medical Royal College's Foundation Programme Committee. We'll be taking you through the aim or purpose of the programme, the educational approach of the curriculum, and how Foundation doctors will be assessed after 2021. Since its inception in 1996, the aims of the UK Foundation Programme have always been to provide a bridge from undergraduate medical studies to postgraduate training, allowing the newly qualified doctor to gain full registration and establish themselves as a practicing clinician. The programme thus forms part of the continuum of medical education and is the last generic stage of training before the doctor progresses to specialty or general practice training. To remain fit for purpose, the Foundation programme must evolve along with medical practice, and the 2021 version of the curriculum has been updated and rewritten to take into account the General Medical Council's generic professional capabilities. In updating the curriculum, we've taken the opportunity to simplify the requirements and to reduce the assessment burden for Foundation doctors. We've also included a new statement regarding the role of the doctor. The new curriculum divides the practice of the doctor into three broad areas: the practicing clinician, the valued healthcare worker, and the responsible professional. Foundation training is based on developing the newly qualified doctor in these areas, and to successfully complete the programme, the Foundation doctor must achieve these three higher level outcomes that the programme consists of. For convenience, each of the three outcomes is divided into a number of Foundation professional capabilities, or FPCs, that the Foundation doctor must acquire and demonstrate as they pass through the programme. The first outcome, the accountable, capable and compassionate clinician, is broken down in a way that will be familiar to the practicing doctor, beginning with information gathering and assessment of the patients, the provision of emergency care, including urgent mental health care, synthesis and planning of treatment, discussion of treatment options with the patient, and delivering certain aspects of that treatment. The final section emphasises the importance of continuity of care and handover of responsibility. The second outcome refers to the doctor working within the multidisciplinary team, ensuring that they are able to build functional working relationships with colleagues, understand the importance of maintaining their own well-being, upholding the values of the healthcare system in which they work, including the need to monitor and improve care and the ability to share their own knowledge with and teach others. The third outcome refers to the doctor as a professional, with an understanding of the ethical and legal framework in which they practice, a commitment to professional development, and an understanding of the breadth of medicine which will aid them in planning a career. The curriculum gives examples of how the Foundation doctor is expected to demonstrate these 13 Foundation professional capabilities, and stresses that they must be learned across different healthcare settings, including those that provide acute care, chronic disease management and population-based community care. The curriculum also stresses the importance of holistic care, emphasising the interaction of physical health, mental health and social well-being, and makes an important statement regarding the parity of mental and physical health care. To successfully complete the programme, the Foundation doctor must demonstrate behaviours compatible with the 13 Foundation professional capabilities across all three broad types of healthcare setting and be able to care for their patients' physical health, mental health and social well-being. The approach taken to training changes little from the previous curriculum, although it does draw on lessons learnt from the last 15 years of the programme to emphasise important aspects of programme delivery. In particular, the 2021 curriculum emphasises the need for good support for Foundation doctors at what is now widely acknowledged as a particularly stressful time and sometimes an intimidating part of their career. The curriculum also recognises the need for extra support for some groups of doctors and makes a clear statement regarding the importance of equitable treatment for all those undertaking the programme. Those supervising foundation doctors must be aware of these issues and are expected to be familiar with the specific needs of foundation doctors. Education providers are required to support these processes, including maintaining records regarding the diversity of those providing training. As with previous curricula, the 2021 iteration assigns the foundation doctor to a series of placements that provide experience across all three broad types of healthcare setting and in all three aspects of holistic care, with the aim of acquiring the necessary generic capabilities that make up the 13 FPCs. In each placement, the foundation doctor will be assigned a clinical supervisor who will oversee their training and provide advice and feedback. The role of the clinical supervisor will be supported by the placement supervision group, which comprises a number of professionals who work alongside the foundation doctor and will also provide guidance and feedback. At the end of the placement supervision group will provide more formal feedback to the clinical supervisor around the foundation doctor's capabilities. Because not all of the FPCs can be fully learned or demonstrated in the workplace by all foundation doctors, the curriculum allows for other methods of learning, including direct learning and self-development. Direct learning is what many foundation supervisors will be familiar with as core foundation teaching, and the curriculum embeds the need for the foundation doctor to attend 30 hours of this teaching to ensure all areas of the curriculum are covered. And in this version of the curriculum, some of this core content learning is specifically defined. These defined topics have been chosen because they represent important aspects of modern medical care, are not always widely taught or practiced, or represent new advances that need to be championed. All those organising the training of foundation doctors should ensure these topics are covered in core teaching, unless foundation doctors in that location will all cover them in the experiential part of their training. The curriculum provides more details on these topics. As well as direct training and core learning, it is expected that foundation doctors will want to develop areas of practice or record other learning that has been of value to them. This might include online modules that they've undertaken or personal reading and reflection. This is designed to encourage personal and professional development, but in some cases, such learning might be undertaken at the direction of the supervisor to remediate a perceived area of weakness. Self-development time can be used for this personal learning. As they progress through their training, foundation doctors will develop their capabilities and are expected to record evidence to reflect this in their portfolio. To guide their training, each foundation doctor will be assigned an educational supervisor who will regularly review their progress against the 13 foundation professional capabilities and provide guidance for other areas of development. As well as being used to monitor the progress against the 13 foundation professional capabilities, some of the evidence recorded in the portfolio will be used to, at the end of the year, to assess the foundation doctor's achievements and to decide if they've met the 3 higher level outcomes. When making such a judgment, those assessing the foundation doctors will put more weight on the evidence that demonstrates what the foundation doctor has done in the workplace than on evidence that shows what they can do or are able to explain. The curriculum calls this the hierarchy of evidence, and it is based on Miller's pyramid. More information about assessment will be covered in the final section of this presentation. In terms of recording progress, a significant amount of evidence against the clinical capabilities, that is higher level outcome 1, is likely to be in the form of supervised learning events, or SLEs, particularly the mini-KECs and DOPs, although the Learn form, which has been piloted in some schools, can be used too. Although previous curricula specified particular numbers of SLEs, the 2021 curriculum does not. The only requirement is to collect sufficient evidence to demonstrate the capabilities. Other feedback that will be familiar to most supervisors remains in use, particularly the multi-source feedback, or TAB, which is likely to be the most useful in demonstrating some of the capabilities within higher level outcome 2, the valued member of the healthcare team. As with SLEs, the main purpose of this tool is as formative assessment of progress to enable the foundation doctor to receive clear feedback, although at the end of the year a successful TAB is required as part of the summative assessment at ARCP. What has changed in the 2021 curriculum is the use of the Placement Supervision Group, or PSG. Again, feedback from the PSG is used formatively throughout training. However, at the end of each placement, more formal feedback from the PSG should be used to inform the clinical supervisor's end of placement report. And at least one satisfactory report supported by PSG feedback is required for successful completion of ARCP. Many SLEs, the PSG feedback and TAB largely represent feedback from the top of the hierarchy of evidence, but some training, especially core and non-core learning, will be used to provide lower level evidence that will complement this and show evidence of general professional development. By the end of each level of training, the portfolio is expected to contain evidence of at least 30 hours of core learning and 30 hours of self-development, which may include self-directed learning, departmental or non-core teaching, and sometimes extra time spent in core learning. Like all doctors, foundation doctors are expected to reflect on their practice. This can be done in a variety of ways, including individually, in groups, and at debrief sessions. Some of this reflection should be recorded in the e-portfolio, and this might contribute to some of the logged non-core learning. In addition, and new for the 2021 curriculum, the foundation doctor is required to complete a summary narrative detailing reflection on their progress through training. This will be guided by the educational supervisor and can be used as a basis to identify areas for personal development and inform personal learning plans. More details on this summary narrative is given in the curriculum, and a separate presentation is available to introduce it further. In this final section of the podcast, we turn our attention to the assessment process that will be used under the new curriculum. Whilst there have been significant changes to the outcomes that will be assessed and the evidence provided, much of the assessment process and tools remain the same and are familiar to UK undergraduates and those involved in postgraduate training. As before, assessment of capability will be made by healthcare professionals that come into contact with the foundation doctor. It is important that feedback is given to foundation doctors contemporaneously to drive improvement and learning. Ideally, feedback will be both verbal and written. The curriculum makes specific reference to the differences between formative and summative assessments and how each are used to inform the foundation doctor's progress. There are a variety of educational tools that feed into the summative assessment forms that will be discussed later in this presentation. When assessing performance, it is essential to consider that some trainees will require adjustments to enable them to achieve the learning outcomes, and the curriculum allows for reasonable adjustments. It is important to recognise the difference between formative and summative assessments. Summative assessment is when the assessment leads to an outcome that is either satisfactory or unsatisfactory and informs whether the doctor can progress through critical progression points, i.e. from F1 to F2 or from F2 to completion of the foundation programme. Formative assessment is where the doctor undertakes experiential learning such as SLEs or reflections, completes a learning log, receives PSG or TAB feedback. It is anticipated the foundation doctor will receive feedback in various forms, evaluating their capabilities in clinical performance, team working and professional development, which map to the 3 higher level outcomes of the programme. These formative assessments will feed into the summative clinical and educational supervisors reports. In F1, the additional summative assessment is the prescribing safety assessment. The curriculum assessment document has a blueprint of assessments and how they relate to the outcomes. It's time to look at the clinical supervisors report. Clinical supervisors report provides an assessment of capability in the working environment. It is informed by the direct supervision of the trainee, evidence from formative tools such as SLEs, feedback from the PSG, learning logs and reflections. Ideally, the full-time trainee will achieve 3 satisfactory clinical supervisor reports, although it may be possible to progress if one post is unsatisfactory, provided the final post is satisfactory. Overall, progress against the curriculum will be overseen by the educational supervisor, who will review the foundation doctor's achievements as they transition from one post to the next. The educational supervisor's end of year report provides a summative assessment of the trainee's overall educational progress. The educational supervisor's end of year report provides crucial information on curriculum coverage, evidenced by the foundation doctor in their e-portfolio. Key to sign off is a range of evidence linked by the foundation doctor to each of the 13 foundation professional capabilities. It also comments on the placement supervision group and tab feedback. In addition, the educational supervisor will review the summary narratives, which will help the foundation doctor justify why they feel they have evidenced each of the learning outcomes. The new curriculum should prove less onerous for the foundation doctor to complete. The key changes to the assessment strategy is that progress focuses directly on curriculum requirements rather than requiring specific numbers of assessments. Foundation doctors collect evidence of performance in the workplace and, where appropriate, link these to the 13 foundation professional capabilities. For each FPC, the educational supervisor should see a range of evidence that reflects Miller's pyramid. So, for example, for FPC1 clinical assessment, the portfolio may contain evidence of learning, such as a teaching session or module, a reflection on their learning, and performance via some SLEs where they have demonstrated directly to the person supervising them that they are competent in this area. FPC2 clinical prioritization may have a teaching session on acute mental health presentations, an SLE focusing on delirium, and a reflection by the trainee. Further supporting evidence might include an SLE on managing an acutely confused patient or evidence of undertaking this in simulation. We would also expect similar evidence for physical healthcare conditions. The e-portfolio will allow up to 10 pieces of evidence per FPC. It is advised that the foundation doctor completes a variety of SLEs as they progress through their training, and then carefully selects the ones that map to the curriculum. The summary narrative will help the trainee select the correct evidence. The supervisor should expect to see evidence of capability in both physical and mental health, and of understanding the importance of social well-being, and over both levels of foundation, evidence of these capabilities in acute care, management of chronic illness, and in community care. Other key changes to assessment are the mandatory use of the placement supervision group. Each trainee will require at least one of these in each level of training. This is in addition to the tab, as the tab and PSG assess different domains. In line with GMC recommendations, there is no specific requirement for completion of a formal ILS course at F1 or an ALS course at F2. It should be noted that the ILS and ALS competencies are covered by the FPCs, specifically FPC2, and foundation doctors must provide evidence that they've achieved these either with a nationally recognised course or appropriate local alternative. Similarly, the specific list of core procedures has been removed from the curriculum, but to complete Foundation Professional Capability 4, Foundation doctors must be able to deliver care in a safe manner, including common procedures. Most UK graduates will already have demonstrated competence in these, and no specific training or assessment will be required, save that which forms part of day-to-day supervision. However, some may need further training, and some IMGs may need more targeted training and assessment in the use of common procedures in the areas in which they work. This slide summarises the blueprint of assessment against the Foundation Professional Capabilities and is available in the curriculum documents. In Foundation, completion of both F1 and F2 are critical progression points. F1 to secure full GMC registration and F2 to progress out of the programme. The FPCs and HLOs are the same at each level, however the behaviours and outcomes progress from F1 to F2, and examples of expected practice and behaviours are given in the curriculum. Reviewing each Foundation Professional Capability as the Foundation Doctor progresses enables spiral learning, where the doctor revisits the learning outcomes, but the knowledge and skills, attitudes and behaviours develop with each training year. Although the PSA must be passed to complete ARCP for F1, it is not an F2 requirement for those who join the programme with full GMC registration. This slide summarises the ARCP requirements, which are made available to Foundation doctors and their trainers. It is available in the curriculum and will form part of the ARCP guide. In summary, the 2021 Foundation Programme curriculum seeks to update Foundation training and simplify the assessment process. It clearly links ongoing training and assessment to curriculum requirements by removing specific requirements about numbers of assessments. There is a clear statement on the equality of mental and physical health care and explicit requirements for an understanding of social well-being as part of healthcare. To complete the programme, Foundation doctors are expected to understand the breadth of medical practice and demonstrate capabilities in acute care settings, chronic disease management and community care. The curriculum also attempts to address issues around differential attainment and provides a clear statement on the need for equality and fairness in training. Thank you for watching this presentation on the 2021 UKFP curriculum. More information is available on the UKFPO website.